turns out into myocardial infarction. This is where the heart becomes ischemic and there's no blood supply going there and the cell is actually dying. All right. So a myocardial infarction occurs when the myocardial tissue is disrupted and severely deprived of oxygen. So the ischemia can lead to necrosis of the tissue if blood supply is not returned. Infraction does not occur instantly, but it evolves over several hours. So that is, the person is having the angina and it either is getting worse or it wasn't treated. Then so that's why they're saying that a myocardial fraction doesn't happen instantly, but it occurs over several hours. So obvious physical changes do not occur to the heart until about 6 hours after the infraction. So what you see, the area may be blue and swollen. So after 48 hours, the infection turned gray with yellow streak developing, which is the neutrophils invading the tissue. By 8 to 10 days after the infection, granulation tissues form. Over 2 to 3 months, it becomes necrotic around the area, scar tissue. So imagine, remember that the heart is a contractile muscle. And if there's scar tissue and it becomes hard, necrotic meaning something is rotting, no oxygen, then the heart will not pump effectively. So not all clients experience the classical symptoms of MI. Women may experience what they call atypical discomfort, shortness of breath, fatigue, and often present with what they call non-STEMI elevation. So an older client may experience shortness of breath, pulmonary edema, dizziness, altered mental status, or dysrhythmias. So risk factors include atherosclerosis, which is what causes angina, coronary artery disease, high cholesterol levels, smoking, hypertension, obese, physical inactivities, impaired glucose tolerance, and even stress can cause it. So what they will do is they'll do some diagnostic studies. So they will do troponin level. So within about 3 hours, the troponin level will increase. And the troponin level will remain elevated up to 7 to 10 days. And I want to say this to you. If the troponin level, say that the patient was admitted in the hospital today. Today is the 13th, right? And the patient was discharged on 4 days after received treatment and discharged on the 17th. So patient came into the emergency room, so they're having chest pain, find out that they have myocardial infarction, they received treatment, and they went home on the 17th. Okay? They come on the 20th and say, oh, I'm feeling chest pain. You cannot do a troponin level again. The reason why you cannot do a troponin level again, because the level is elevated in the blood for 10 days, and this is 10 days. You get what I'm saying? So you don't know if it is an old MI or if it is a new one. So the troponin level are still high. So they may take the troponin level, but it's not a good indicator because the levels were high because of what happened on the 13th or before the 13th. You get what I'm saying? So they will do, they may do it, but it's not a good indicator because you won't know if it's new. So they will do a total creatine kinase level. So the level raised within 6 hours after the onset of the chest pain. The level peaks within 18 hours after damage, death of the tissue. They'll do also a CKMB isoenzyme, and this peaks elevation occur 18 hours after the onset of the chest pain, and the levels return to normal within 48 to 72 hours. So these are two of the tests that they will do if the patient return, because if you can see that, especially with the CKMB, that it returns to normal level within 72 hours. So if the patient come back on day 20 and say, oh, I'm feeling chest pain, and they see the level goes up again, they'll know that, okay, then it is a new myocardial infarction. So
Mm.
myoglobin level raises within the 2 hours after cell death, and with a rapid decline in the levels after 7 hours. White blood cell will be elevated, and white blood cell count up to 20,000 cells appears on the second day following the MI and lasts up to 1 week. The pain, they will experience pain, crushing sternum pain. The pain may radiate to the jaw, the back. The pain may occur without causes, primarily early in the morning. And one of the signs that is a myocardial infarction is that the pain is unrelieved by rest or nitro
Mm.
and is relieved only by opioids. So myocardial infarction, they have what they call MONA. The acronym is MONA, which they will give morphine, oxygen, and they will give nitro. So that's the acronym for the treatment for the myocardial infarction. They'll give morphine, oxygen, they may give nitro, and also aspirin. So they may complain of nausea, vomiting, they may have diaphoresis, dyspnea, dysrhythmia, feeling of fear and anxiety, they may have coldness to extremities, and even cyanosis. So intervention in acute stage, pain relief, increase oxygen supply to the myocardium. So you give morphine, and I guess maybe I'm repeating myself. Morphine is a priority to manage the pain in the client having an MI. Obtain a description of the chest discomfort. You want to give the oxygen via nasal cannula as prescribed. Assess vital signs for cardiovascular status. Also, the patient should be on bed rest and placed in a semi-forward position. This enhances comfort and tissue oxygenation, and stay with the client. Establish an IV access route, because then further testing and medication may be needed.
Mm.
So there's a couple of complications with myocardial infarction. They may have dysrhythmia, heart failure, pulmonary edema, cardiogenic shock, the condition in which the heart just suddenly cannot pump enough blood to meet the body's demand. There are different types of shock. There's a cardiogenic shock, there's a hemorrhagic shock, there's a shock that is caused by infection or result of infection. So there are different types of shock. Whatever it is, whatever the shock is, it is not enough blood.
Mm.
So that is shock. But there are different things that causes the shock. And in this case, when the blood cannot, when the heart cannot pump the blood to the body, then the person is going to go into shock, which this is cardiogenic because it is caused by the heart.
Yeah.
Unlike hemorrhagic shock, a hemorrhagic shock would be because someone is bleeding out. They could have a puncture, a cut, or something, and they're bleeding out and they don't have enough blood in the body. So they go into shock, but it's called a hemorrhagic shock because
Mm.
not enough blood is caused by hemorrhaging. Or hypovolemic shock or septic shock. Septic shock is where they have an infection. Now, I think I mentioned to you yesterday that there are particles inside our body, inside our blood. But when you have things coming in, it will decrease the amount of fluid. And that is what happens when you have sepsis shock. Sepsis shock is a lot of infection in the blood, decreasing the amount of fluid available, so they go into shock. All right. So continuing on to myocardia. So they may have phlebitis, pericarditis, mitral valve insufficiency, post-infraction angina, ventricular eruption, and may even have something called Dressler's syndrome, which what that is a combination of pericarditis, pericardial infusion, and pleural effusion. Now, I mentioned to you when we first started that the pericardium sac is a sac that encloses the heart, and sometimes that get infected. And I also show you the cavity in the pericardial area. Too much fluid in that area can cause pericardial effusion, okay, or cardiac tamponade. So obtain EKG, administer dysrhythmic medication, administer thrombolytic therapy within the first 6 hours of the coronary event. You want to monitor signs of bleeding if the client is receiving thrombolytic therapy, monitor log values, beta blockers, okay? And what they cause is low heart, they actually slows down the heart because remember, the heart not getting enough oxygen, it started rotting already, necrotic, and they don't want the heart to work too hard because then the harder it works is the more oxygen it's going to need. So when you slow down the heart, then you don't need that much oxygen to work. So one of the side effect of this too is bradycardia. Monitor the cardiac dysrhythmia because tachycardia and PVC frequently occur in the last few hours after an MI. So after an MI, the person may have tachycardia or premature ventricular contractions. Assess distal peripheral pulse and skin temperature because poor cardiac output may identify by cold diaphoretic skin and diminished or absent pulse. Assess respiratory rate and breathing for signs of heart failure as indicated by the presence of crackling or wheezing or dependent edema. So the person should maintain bed rest for 24 to 36 hours as prescribed. Allow the client to stand or void or use a bedside commode if prescribed. Provide range of motion exercise. What this does is prevent any kind of thrombus formation and also help with muscle strength. Also progress to dangling the leg at the bedside or out of bed at the chair for at least 30 minutes a time per day. Progress to ambulation in the client's room, into the bathroom, and into hallway 3 times a day. Monitor complication and encourage the client to verbalize any feelings as it regards to an MI.